Hello, thanks for listening to the Total Knee Tips and Pearls podcast. This is Adam Rosen, your host. I'm a fellowship-trained orthopedic surgeon who specializes in joint replacement. In these episodes, I'm going to share with you a lot of my tips and tricks and review classic articles and current implant designs. Thanks for tuning in, and on with the show. Hello and welcome back. This is Adam Rosen, and you're listening to the Total Knee Tips and Pearls podcast. And again, in this season, I'm actually doing that whole third season mainly for the primary care. So if you're a primary care provider, maybe you're looking for some additional orthopedic information and knowledge, this is the place, and I hope you like it. And if so, please refer this on to some of your other internal medicine colleagues. In today's episode, though, I want to go into some deep detail on, and I hate the term, surgical clearance, but the idea of surgical optimization or surgical stratification. A lot of times a orthopedic surgeon may tell a patient, you need to see your primary and get clearance or get stratification. And some primaries and internists I find are very, specific. Some not so much. I find some cardiologists, they're cleared, they're not cleared, and other cardiologists are very detailed into X, Y, Z, and looking for these parameters and information both for me and the cardiologist. So, at the beginning of the day, I'm still a doctor. I always kind of call myself the orthopedic internist because I'm still worried about patient's health and well-being, not just the surgical problem or not just the orthopedic problem. So a lot of times I'm thinking when I meet a patient, even at the initial consult, what are the things that I need to worry about should this patient become a surgical candidate? And these are the things that I really look for from the primary. I know some of us probably send it simply for medical legal reasons, and some surgeons may be pretty well versed and have the ability and capability and confidence to care for all their medical issues. I feel pretty confident, taking care of those issues, but I really do think it's important that the primary care see them just so they can look for things that maybe I haven't thought of, and also so they know that their patient is undergoing surgery, so post-operatively or peri-operatively, if there's issues, they're not caught off guard that something was going on. So I'm going to go through this initially, and the obvious thing a lot of times is labs. We got to get labs because sometimes we'll do labs or sometimes the primary care doctor does labs. But what I find, unfortunately, is that patients sometimes have labs that are abnormal and they're not really acted upon. And maybe somebody doesn't think that they're a big issue. So from our literature, and specifically, I'm going to talk more about the total joint world, there's some clear evidence on what may or may not increase a patient's risk. Now, obviously, if someone's having a knee replacement, that pre-op may be very different from somebody undergoing a trigger finger release or some young kid who's undergoing an ACL reconstruction. You probably won't even see them. But I think most of the patients that we send for preoperative evaluation are the older individuals, say greater than 50, undergoing larger, more complex orthopedic surgeries such as back operations and joint replacements. So when we talk about the labs, everybody's going to get a CBC. We're interested, obviously, if the white count is elevated, why? Do they have a UTI? Do they have pneumonia? Do they have an underlying hematologic disorder? And has that been diagnosed? But it's also important that if their leukocyte count is low, even if that's normal for the patient, that patient carries an increased risk of complication and infection. So we want to just know that that normal range is important. If it's low or high, additional evaluation workup, possibly involvement with hemog, may be indicated. The next thing with the CBC is your hemoglobin and hematocrit. A lot of times I've had patients that have anemia that are, sent from their primary as no comment or anemia of chronic disease. However, they didn't take the next step. Prove to me that it's anemia of chronic disease, and if so, treat it. So if I have somebody with anemia, I am looking for and expecting that their B12 and their iron studies are checked, because if they have anemia secondary to nutritional deficiencies, then we need to replete their B12 or we need to replete their iron and then reassess their blood count when it comes back up. Why? Because if they have anemia preoperatively, and we're not even going to talk about whether or not they have cardiac disease, but a lower blood count coming into surgery, and a lot of studies have looked at hemoglobins of 11 or 11.5, lower than that, the risk of transfusion is higher. And nowadays, transfusions are given less than 1% of the time. So if somebody has a transfusion, now they've increased the risk of infection. They have an increased risk of other complications, like a transfusion reaction, getting the wrong blood. But also what we find is that low blood count coming in lowers their blood count post-operatively. It inhibits their ability to do physical therapy. It delays their discharge from the hospital. It worsens their recovery. So if we can correct it ahead of time, let's correct it. So B12 low, correct it. Iron low, correct it. Then recheck. If both of those parameters are normal, let's look for other issues. Do they have chronic kidney disease? Do they need to see a hematologist? Maybe everything's normal and they do have just anemia of chronic disease. Would they benefit from Procrit? This is something we would order to try to boost their blood count prior to this elective surgery. And then they come in at a safer margin and decrease the risk of a transfusion need. Okay, platelets. Look at platelets. Some people, if they have a chronic history of low platelets, why? Do they have a true diagnosis? Because again, if they have dysfunctional platelets or low platelets, that patient is going to be at increased risk for bleeding. And the increased risk of bleeding, again, increases the transfusion issues, all those issues with ability to participate with physical therapy. But also, if they bleed, that increases the risk of wound drainage and wound infection and knee infection. So next, let's look at the metabolic profile. And I strongly recommend that we get the comprehensive in all of our patients. So obviously, sodium, potassium, low. Do they have kidney disease? Are they on some diuretic or is there some medication? So adjust those. But creatinine and overall kidney function. So what's interesting is if you look at all of these different potential risk factors, that kidney disease alone is one of those in the total joint world that carries one of the highest risks of perioperative complication. So obviously, if they have chronic kidney disease and it's been worked up and treated and stable, we may not be able to improve upon it. However, if it's a new finding, we need to look into why and is there a way to improve it prior to surgery. The other part, which is important with the comprehensive, is looking at their albumin. So we know that with an albumin less than 3.5, that their risk of wound complication and infection is significantly higher. So if somebody has low albumin preoperatively, that is a no-go for elective surgery. Why? We want to correct it first. What is their reason for malnutrition? They may need a whole malnutrition workup. Maybe they have underlying cancer that hasn't been diagnosed yet. Maybe there's some other issue, but they may need to increase those protein stores and nutrition, may need to see a nutritionist to get their albumin into a safe, normal range prior to this elective surgery to prevent the risk of a perioperative problem or complication. Now, occasionally someone's albumin's low and we've had them see a nutritionist. Let's check a prealbumin. Let's make sure that we're making the turn. Is the prealbumin returned to normal? Maybe the albumin's just a smidge low. Maybe it's safe in a particular individual with no other risk factors of proceeding with elective surgery. But that gives us the ability that the change that we've made with their nutrition because of the low albumin is working. Now, next, diabetes. I can't tell you how many times I've diagnosed patients with diabetes because I'm looking at pre-op labs and I see 3, 4, 5 random chemistries with elevated glucose. Patient doesn't have a history of diabetes. So I'm the one ordering an A1C. A1C comes back at 9. This person has diabetes. So that's just kind of, the common sense in the medical world. Someone with multiple random sugars that are elevated, you got to do your due diligence and take another look and see what's going on. But when we talk about diabetes, depending on the study, you're reading 7, 7.5, but basically uncontrolled diabetes, A1C greater than 7, significantly higher complication rate, not only for infection, but all complications, stroke, heart attack, other complications as well. So we're always looking for, if you have diabetes, to make sure that it's controlled, A1C of less than 7. Occasionally I have a patient that's a brittle diabetic, followed by endocrinology closely, maybe on an insulin pump. 7.4 is as great as they ever have been and ever can get. And the patient has to understand the risk, and they may be willing to increase that, but with strict perioperative hospitalist involvement and endocrinology follow-up. But uncontrolled diabetes definitely has to be treated and addressed prior to elective surgery. Now, what about coag specifically? PTINR is elevated, they're on warfarin. Okay, makes sense. But, their coags are abnormally high, and they're not on a blood thinner. The question is why? Did they have underlying liver disease? Because again, this is a patient that may be at increased risk for bleeding. So if you can figure it out, great. If not, ask for help. Send them to HEMONC, figure out what's going on. LFTs aren't a regular occurrence, but if somebody does have a history of chronic liver disease, we want to know because, again, some of these liver patients, they just don't produce normal blood clotting factors, and they can have significant, third spacing and wound drainage and bleeding complications. And again, may not always be fixable or correctable, but you want to know going in if they have a history of liver disease, where does their liver disease fall right now? And is there anything that we can do to address or change that? Now, what about vitamin D? So, I routinely check vitamin D for my pre-op patients. Why? I did a study a bunch of years back because I was curious, looking at Southern California, sun, older patients undergoing joint replacements, and actually found almost 50% were either low or deficient. So we now check why. It doesn't necessarily directly affect the knee replacement. However, it is part of the bone health. And there's lots of other studies constantly coming out where vitamin D deficiency may be associated with other disease issues. So we want to try to catch vitamin D deficiency early, that in the hopes that we can hopefully prevent osteoporosis later. Because someone that does have osteoporosis at the time of joint replacement, back surgery, may have an increased risk of fracture or failure of bone ingrowth. Some of the spine guys, before large corrections, may even put them on medications to improve their bone structural integrity prior to those elective surgeries. But vitamin D, I find, is a good first step to figure out where a patient stands. Nicotine. So if somebody's a smoker, they got to quit. It's one of those things that nicotine is a modifiable risk factor. And if someone's a heavy smoker, the risk of wound complication, venothromboembolic disease all go up. And we got to get those patients to quit. I'd say over the years, I can get patients to quit before and for a number of weeks after. And about 50% of those go back to their old habits. But you got to make sure that they quit pre and post-operatively to lower that risk of complication. In patients that don't listen and I'm concerned, I will check levels to make sure that prior to surgery that the nicotine is out of their system, and if they've said they've quit, that they really did quit. Now, the next kind of part of the entire history physical, obviously I'm not going to go into detail, listening to the heart, lungs, looking for murmurs, carotid bruits, all important things, but vital signs and the BMI. Why?
We'll be back after a quick break.
Once a person is triggered, there are biological changes that happen in the brain that zap your energy, motivation, and sense of pleasure. Now, that in itself is not depression until people get into the depressive loop. It's very easy for people to stop doing things.
Yeah.
And you get into what we call an avoidance pattern of behavior. You stop doing things that give you a sense of mastery and a sense of pleasure, right? And you withdraw because the brain's basically like, hey, if you're not going to do this stuff, then I'm not going to give you the chemistry you need to want to do it.
Yeah.
So the less you do, the less you feel like doing. The less you feel like doing, the less you do. Now you're in the loop.
It is one of those things that I commonly see not mentioned, at least in the medical record. Again, we're all taught if you didn't document it, you didn't do it. So if you talk to a patient about their weight, that's great. If you didn't document it, you didn't do it. And I see a lot of patients referred to orthopedic surgery with BMIs of greater than 40. And nowhere in the medical record does anybody talk to them about their morbid obesity and weight loss and nutrition and health lifestyle changes. So every doc that you talk to is going to have some different parameters. But most have some rules. And, if you go to Europe, some of those health insurance systems, BMI's got to be under 35. I've even seen some insurance companies that have said surgery denied unless BMI is less than 35 or they've had 6 months of consecutive weight loss in a physician supervised program. So for me, my goal for all patients prior to surgery is a BMI of 35 or less. I may tell them long term, we'd like to get it lower, but if you're overweight, greater than 35 or greater than 40, we're going to aim for a BMI of 35. And I have a whole separate thing that I do with patients as far as nutrition and weight loss and healthy eating and, nutritionists in the metabolic clinic. But if your patient is a BMI of 42, understand that you got to get them lower and you have to work with them and you have to offer them assistance and help and referrals to get that down, because we know that if someone's BMI is high, that the risk of wound infection is greater, wound complications greater, thromboembolic disease is greater, implant failure is greater. Sometimes the risk of ligament ruptures, failures, extensor mechanism, tendon ruptures, all higher risk. Long term, the implant may fail earlier. People don't realize these surgeries are a lot longer and more difficult for the staff, but also for anesthesia and the nurses postoperatively, just managing these patients, because a lot of them also have other comorbidities like diabetes and sleep apnea. So if someone's BMI is over 40, I'm talking to them about getting it down to 35. Now, if I've had someone who shows up on my doorstep with a BMI of 50, and we have this discussion, and they get their BMI from 50 down to 41, I'm not going to say no. They did a great job. They made huge improvements in their health that I will say yes, as long as they are aware and understand the risks that come with that. So if you're seeing these patients that have high BMIs, make sure that you're talking to them in detail about getting that risk down. And again, I talk to them. It's not just a weight thing. It's not just a number thing. It's that it's a modifiable risk factor. And if they come in and have elective surgery with those high BMIs, they are increasing the chance that they could have a poor outcome and an infection, wound complication, need for revision surgery, and all of those things can be improved upon if they can lower their weight preoperatively. Now, there's a big discussion and nobody knows, if they're really heavy, do you have them see bariatric, and is bariatric surgery an option prior to knee replacement? The jury's out. I've seen studies both ways. But what is interesting to know is that occasionally we will see underweight patients. So somebody with a BMI under 18 actually has even more risks than the person with a BMI of over 40. So if somebody's underweight, then you make sure that that person also needs a nutritionist and figure out why they're underweight, and then make sure that you correct that and get them into a healthier weight range prior to surgery. But what's also important to understand is that both of those groups, the morbidly obese and the underweight, can be malnourished. And that's where you can see someone with a BMI of 42 and has a low albumin. So we have to make sure that they're eating well and make sure that they're as safe as possible prior to this elective surgery. Now, other things to just think about and be aware of. Alcohol use. If a patient is a heavy drinker, again, they're probably going to have abnormal coags, abnormal LFTs, abnormal nutrition, but it is important for those patients to quit preoperatively, and it may need additional assistance and help and medications and therapy, but those patients have to get off of it because the risks are significantly higher. But I counsel all my patients, if they're drinking, to make sure that during this perioperative period, they keep it to a minimum, a drink, no more than 2 drinks a day. But there's someone that's a heavy drinker, 6-pack a day or bottle of wine a night, that's a problem, and that increases the risk. So that has to be modified prior to the surgery. Next things, as part of your pre-op assessment with the patients that you know so well, do they have underlying anxiety or depression? Because there have been some studies showing that those patients do have more problems after surgery as far as pain and physical therapy and outcomes. So, I do a lot talking to my patients if I recognize that in talking to them, if it's not diagnosed, if they have those personality traits, or if they have a true diagnosis and maybe they're on medications, and making sure that, hey, if they have a therapist, I want also their therapist knowing that they have surgery coming up. This is a stress-producing event. This is an anxiety-producing event. We know that education helps, so the more they understand of what's going to happen and what's coming and what they're expected, that will help. But sometimes these anxiety and depression symptoms can actually drive pain levels higher, which can lead to a greater need for medications that have additional side effects. So making sure that those patients are aware of what's coming and that they have coping mechanisms and skills. I refer a lot of patients to some of the online apps because it's something that they can start at home preoperatively that may help overall every day, the rest of their life, these anxiety disorders, but especially during the perioperative period. Now, what about venothromboembolic disease? So understand, I've heard people talk about it, low risk, high risk, this, everybody has a risk. So I never use the word low risk, that when we're doing joint replacement surgery, there is a normal risk that patients can develop a lower extremity DVT or a pulmonary embolus. If somebody is high risk, that is great information for us to have if we haven't already figured that out from our evaluation of the patient. So if a patient had a DVT many years ago, maybe that's not in our system. Maybe the patient didn't even remember. That changes the ball game, because for most places now in the world, a normal risk total joint replacement patient undergoes aspirin as chemical prophylaxis. And I am not going to go into the hematologic issues because I understand the difference between arterial clots and venous clots. But what's interesting is that it has now become sort of a standard of care, and there's data to support it. It is confusing and complicated, but also times have changed where the other aspect of venothromboembolic disease prevention is early ambulation. Patients aren't in the hospital anymore for 3 to 7 days. They're not at bed rest for 1 to 2 days. They're up and standing and walking the day of surgery, and usually home the day of surgery or the following day. So that early ambulation has played a big factor in reducing the risk of venothromboembolic disease. And also, most patients while in the hospital also have mechanical devices, and many patients have some type of regional anesthesia. So it's not just that we went from things like Coumadin and Lovenox to aspirin, it's that the therapy and the recovery time and the amount of ambulation has all changed. What was interesting, however, there was a study many years ago in the British Journal that actually looked not at venothromboembolic incidence or prevalence, but it looked at MI and stroke. And it looked at 2 groups, aspirin versus warfarin. And what it found is patients on aspirin after total joint replacement had a lower incidence of stroke and heart attack. So there's some secondary benefit in a lot of patients when we do certain things, even though it may not be for that immediate reason. We're also seeing that now with pain management, that the idea of postoperative fever has almost disappeared because for pain management, many patients are on scheduled acetaminophen. So there's that secondary benefit that we're not seeing the postoperative fevers like we used to anymore. But it's important, again, that we understand, does a patient have active cancer that we're not aware of? Does the patient have a history of venothromboembolic disease? Do they have some underlying protein C/S deficiency that may make them more prone to a DVT? That's important information for us. But I would strongly recommend that you always say, these are the patient's risk factors for venothromboembolic disease, and the decision for treatment is up to the surgeon. Why? It's surgeon dependent, patient dependent, insurance dependent. I remember one patient has no risk factors. I had planned on aspirin, and they saw their primary and they had recommended enoxaparin. And then they saw a cardiologist because they had another cardiology issue that was stable, and they recommended Eliquis. So now in the medical record, you have 3 different doctors recommending different things. It kind of gets you stuck because if they did happen to get a DVT on aspirin, because it can happen, then somebody says, well, why didn't you do what the primary said? Or why didn't you do what the cardiologist said? And if I put them on one of those drugs and they get a bleeding complication, which with a lot of the heavy-duty chemical blood thinners can be as high as 15%, somebody says, well, why did you put them on that? You would plan on using aspirin. So I would just recommend don't pick a drug because even I occasionally, if I'm putting someone on a chemical, maybe I chose to use Xarelto. Their insurance doesn't cover Xarelto, but they will cover Eliquis. So we'll switch based on what their insurer will carry. But it is important to say, high risk or normal risk. The other thing is important is some drug-resistant bacterial infection in the past. We nasal swab all of our patients. Mainly we're looking for MRSA carriers so we can add vancomycin. But let's say the patient had a wound in your office 3 years ago and you swabbed it and it came back as MRSA and you put them on Bactrim. And that's not in my medical record. How do I know that the patient has a history of MRSA? Maybe their nasal swab is negative for MRSA. So I would like to know that they've had a history of MRSA in the past, or even like a drug-resistant UTI, just so I'm aware of what the potential bacterial agents in that individual are. Other thing is the skin. So, obviously as surgeons, we're looking at the wound that we're going to work on or the area of the body we're going to work on. But it is important, does the patient have chronic lymphedema? Have they been to the lymphedema clinic? Do they have psoriasis? Is it under control? I talk to my patients if they have psoriasis, but they come in the day of surgery and they have a psoriatic plaque that breaks out over where I'm going to do my surgical incision, then we have to cancel surgery the day and plan at a later date because it increases the risk of a complication. Do they have underlying lesions? There's a gentleman I saw not too long ago who had a lesion over the front of his knee that we sent to dermatology and turned out to be a skin cancer, but something that we have to look for because it was right in the area of where the surgical wound would be. Next thing, vascular. Check people's pulses. I have the luxury of I'm looking at people's x-rays, and a lot of times I'll see these calcific angiograms essentially of their vessels. So that prompts me to think, does this person have vascular disease? But I have a number of patients who get cleared by primary or subspecialists, and I can't palpate a pulse. They don't have Frank Ruber and they don't complain of vascular claudication, but the pulses aren't normal, and I'll get an arterial ultrasound, and lo and behold, they have complete blockage or stenosis requiring a stent. Now surgery for their joint replacement is delayed. So, really think about their vascular status and check pulses, and if you can't feel them, you need to do your due diligence and check an arterial study. If they have pulmonary disease, if they have cardiac disease, if they have, liver disease, if they have other subspecialty issues, that's where you may have to have those patients see their subspecialists to get a specific recommendation at the time of surgery for that extra specific problem that they're seeing their subspecialist for. And lastly, think about neuro. I know a lot of times families don't always necessarily pick up on Alzheimer's or dementia because, they're hanging out with their spouse or mom and dad, and they see these slow, subtle changes. And, I meet people, and I like to believe I'm a pretty good judge of character, but, I ask patients questions, they're forgetful, or, they always respond to their family member for answers. And, I beg the question, do they have, a diagnosis? Have they been told they have dementia? And, many times no. Or maybe they were thinking about it, they've been followed, they've been watching it, and they haven't been placed on medication yet. But I'm looking for that because those are the patients that with anesthesia, very commonly can develop postoperative delirium. So I'm making the habit to talk to the spouse or talk to the family members and say, hey, listen, mom or dad, they're getting a little older, they seem a little forgetful, it may just be that. But if they have the early signs of Alzheimer's or dementia, and then they have anesthesia, and then they're in a hospital, maybe they don't get a good night's sleep the night before, they have some pain medicine on board, this person could easily have postoperative delirium. And I go into what delirium is, and there's really no major treatment for it, that we just have to watch them and just so they're aware. And I find that when it does happen, it's a lot less scary for the significant other or for the family member because they're used to it, or not that they're used to it, but they're aware of it. And then lastly, it's not something for the medical doctor necessarily to do, but something as the orthopedic surgeon, I typically will send my patients out as for dental eval. So especially if you're talking to your patients, you're examining them, you look at the teeth, sometimes just a look in the mouth can tell you something's off. So, I've had patients that, they see the dentist 3-4 times a year, they get regular cleanings, they're perfect. But I still want to note from the dentist, they don't have any cavities. But these patients that have very poor dentition or haven't been to the dentist in years, the mouth is a source of infection. So if they have rotten teeth, they could be seeding bacteria every time they brush their teeth into their bloodstream, which could potentially seed the freshly operated total knee, and that could lead to an infection. So if people have major dental issues, I have them get evaluated, treated prior to proceeding with their elective total joint replacement. So that's kind of all the sort of medical things in a nutshell that I'm looking for and I'm thinking about. And, I'm sure the majority of you probably have that dialed. Some of you maybe, not necessarily sure as to exactly what, we're looking for. And again, I'm not sure every orthopedic surgeon is looking for this, but there's pretty clear data on every one of those topics that I talked about that may increase the risk of a complication. And again, mostly in the total joint world, obviously lower risk, minor surgeries, outpatient kind of things, the risk, the issues with those surgeries are a lot less. But, for the bigger surgeries, this is what we're looking for. This is what we're thinking about. If you have questions, ask your local orthopedist. If they're referring you a lot of patients, have the discussion. Hey, what things are you looking for? I'm constantly trying to refer people back that, I'll say, hey, this was abnormal. I saw that you okayed them for surgery, but I'm going to do this, this, and this. Let's take a look at that together. So hopefully next time they remember, hey, when this is abnormal, I'm going to be looking for these other things. And this way, I think you're going to take your patients that you've cared for over all of these years and put them in the safest possible window for them to have this elective surgery to really minimize the risk that some complication could occur. And not that we can prevent every complication, but again, by being proactive and looking for all of these parameters, you're going to lower that patient's risk significantly. So thanks again for listening. Again, if you have friends, colleagues that you think would benefit from this series, please refer them on and kind of forward this podcast on. And again, if you have specific topics, I'm going to start going through topics specifically for the non-orthopedist. please, shoot me a line on Twitter, email, and I'll try to include those topics in upcoming podcast episodes. Until next time, this is Adam Rosen. You've been listening to the Total Knee Tips and Pearls podcast, season 3, which is geared for the primary care provider. Until next time, stay safe. You've been listening to the Total Knee Tips and Pearls podcast. Make sure that you're subscribed so you'll be notified of future episodes. And please take the time to leave a review. It helps other people like you find the show. Until next time, stay safe.